Audio course on pet and gestational hypertension. Episode 4, Prediction and Prevention. Let us begin before the patient is hypertensive. She is 12 weeks. Her blood pressure is normal. She has chronic hypertension in her chart, a prior pregnancy complicated by early preeclampsia, and a body mass index in the obese range. Nothing is happening today, but the future pregnancy has already declared a risk pattern. Prevention in preeclampsia is not about guessing perfectly. It is about identifying patients whose placental and vascular risk is high enough that low-risk interventions are worth starting early. The first layer is clinical risk. High-risk factors across major guidelines include prior preeclampsia, chronic hypertension, chronic kidney disease, pregestational diabetes, autoimmune disease, such as SLE or antiphospholipid syndrome, and multifetal gestation. Moderate risk factors include nulliparity, obesity, maternal age over 40, family history, a long interpregnancy interval, assisted reproduction, and elevated early pregnancy blood pressure. Clinical risk factors are useful because they are available everywhere, but they are not highly sensitive for preterm preeclampsia. ISSHP notes that multivariable screening performs better when it combines maternal factors, blood pressure, uterine artery Doppler, and PLGF. The Israeli position paper also discusses first trimester algorithms that detect much of early preeclampsia, but with low positive predictive value in low-risk populations and dependence on local resources. So the first teaching point is this: risk factor screening is the minimum. Multivariable screening is more biologically rich where it is available and quality controlled. Positive predictive value is not a statistical decoration here. It changes patient care. A screening model can detect many cases and still produce many false positives when the outcome is uncommon. That means counseling, aspirin decisions, follow-up intensity, and anxiety must be handled carefully. The goal is not to label a normal 12-week patient as diseased. The goal is to identify enough excess risk to justify a safe preventive intervention and a smarter surveillance plan. Now, let us talk about aspirin. Aspirin is the main pharmacologic prevention tool, but it works best when you understand what problem it is trying to modify. In preeclampsia, there is abnormal placentation, platelet activation, vasoconstriction, inflammation, and endothelial dysfunction. Aspirin irreversibly inhibits COX-1. That lowers thromboxane A2, a platelet-derived vasoconstrictor and pro-aggregatory signal. It helps rebalance the thromboxane to prostacyclin relationship toward less platelet aggregation and less vasoconstriction. Sawmans adds another layer. Aspirin may also trigger anti-inflammatory lipoxins, increase interleukin-10 and nitric oxide, and reduce tumor necrosis factor alpha. So aspirin is not just a blood thinner. It is an antiplatelet and anti-inflammatory intervention aimed at placental vascular development and maternal endothelial stress. Timing matters. The benefit is strongest when aspirin starts before 16 weeks. That makes physiologic sense. Spiral artery remodeling and early placental development are still being shaped. If you begin after the disease architecture is already established, the prevention window is narrower. Sawmans reviewed randomized trials and found that aspirin started before 16 weeks reduced preeclampsia, early onset preeclampsia, preterm delivery, and small for gestational age infants. Starting at or after 16 weeks showed less benefit. Dose matters too, but guidelines differ. ACOG commonly recommends 81 milligrams daily for high-risk patients, started between 12 and 28 weeks, optimally before 16 weeks. NICE recommends 75 to 150 milligrams from 12 weeks for patients with risk factors. ISSHP recommends 150 milligrams at night after multivariable screening, or 100 to 162 milligrams per day after clinical risk and BP screening. Sawmans strongly recommends 150 milligrams daily for high-risk women, preferably before 16 weeks, often at bedtime. Why have newer guidelines moved toward higher doses? Pregnancy increases platelet turnover. Higher body mass may reduce aspirin effect. Some patients have apparent platelet insensitivity at lower doses. The aspir-style evidence supports 150 milligrams nightly for screen-positive women, especially for preventing preterm preeclampsia.
Night dosing is not just a ritual in these protocols. It comes from the idea that platelet activation and blood pressure biology may have circadian behavior, and from the way major prevention trials were designed. That does not mean every patient everywhere must receive 150 milligrams at night, but it explains why several international protocols prefer that strategy for high-risk or screen-positive patients. But do not turn this into universal aspirin without thought. Universal aspirin for low-risk nulliparase is not routine in the guidelines because benefit is small, adherence may be lower, and bleeding signals exist. Prevention is still risk-based. Stopping aspirin also varies. ISSHP suggests stopping by 36 weeks. SOMANS recommends individualized cessation between 34 weeks and delivery, considering bleeding risk and shared decision-making. Local practice matters. Now, calcium. Calcium is not aspirin. Its mechanism is less certain, and its benefit depends strongly on baseline intake. The working model is that low calcium intake may stimulate parathyroid hormone or renin release. That can increase vascular smooth muscle intracellular calcium and promote vasoconstriction. Supplementation may reduce this vasoconstrictive tendency and improve uteroplacental resistance. ISSHP recommends at least 500 milligrams per day for women whose dietary calcium intake is below 900 milligrams per day. SOMZ recommends supplementation when dietary intake is below 1 gram per day and reports that high-dose supplementation above 1 gram per day reduces preeclampsia and gestational hypertension in low-intake women. In adequate intake populations, benefit is not established. So the resident memory point is simple. Calcium prevents preeclampsia when calcium intake is low. It is not a universal vascular drug for everyone. Exercise is another prevention tool, but again, context matters. ISSHP cites randomized trial evidence that exercise reduces gestational hypertension and preeclampsia. SOMANZ recommends 2.5 to 5 hours per week of moderate intensity aerobic, stretching, or resistance exercise as routine pregnancy well-being with hypertensive disorder benefit. But established preeclampsia is different. Once the disease exists, exercise is contraindicated, and gestational hypertension requires caution depending on severity and local guidance. Exercise is prevention and general health, not treatment of active disease. Now let us talk about what not to use. This is where mechanisms can mislead you. Salt restriction sounds plausible. Oxidative stress makes vitamin C and E sound plausible. Angiogenic imbalance makes statins and proton pump inhibitors sound plausible. Coagulation and placental thrombosis make LMWH sound plausible. Inflammation makes fish oil and other supplements sound plausible. But plausible is not proven. The corpus does not support routine use of salt restriction, fish oil specifically for preeclampsia prevention, garlic, vitamin C and E, oral magnesium, progesterone, statins outside research or another indication, LMWH in patients without antiphospholipid syndrome or another anticoagulation indication, proton pump inhibitors, clopidogrel, or similar novel agents solely to prevent preeclampsia. This is an important professional habit. Do not teach mechanisms as if they are outcomes. A mechanism is a reason to study an intervention. It is not a reason to prescribe it when trials do not show patient benefit. Let us close with the prevention hierarchy. First, identify risk early. At minimum, use clinical risk factors. Where available and validated, consider multivariable first trimester screening. Second,
Use aspirin for patients at increased risk. Started early, ideally before 16 weeks, with dose and stopping time aligned to local guideline. Third, address calcium only when intake is low. Fourth, encourage pregnancy-appropriate exercise before disease develops. Fifth, do not add unproven therapies simply because the mechanism sounds attractive. The resident reflex is this: prevention is won early. Aspirin belongs before the disease declares itself. Calcium belongs where intake is low. Exercise belongs before active disease. And plausible biology must still answer to outcome evidence.